So many of my colleagues in alternative medicine are scrambling to add IV services to their clinics. I wanted to take a closer look at the clinical evidence behind the treatments, and I wanted to know if they work or not. Because I'm hearing from more and more patients who tell me that they felt like they were given a sales job at these clinics and that they were not given medical care. And a few were hurt. So I felt like it was time to take a deeper look into the evidence behind the treatments, and I'm going to share what I learned with you. And before we dive into those treatments, a quick request. If you learn anything from this video, please pass it along to someone who would benefit from it. My goal is to teach more doctors how to practice simple and effective functional medicine, and growing this channel is a big part of doing that. Okay, so IV vitamin C is the big one, right? This has got to be the most common treatment, IV treatment given in alternative medicine. And the first study is really, really interesting here. So in this study, some researchers kind of went undercover almost. They attended the same alternative medicine conference that was hosted in 2006 and 2008, and they were surveying practitioners. How much vitamin C do you give? Who is getting it? How quickly are you giving it? And it's not how effective it is, just like, let's get some facts on how often this is happening. And, in the 2-year period, it's 2025 now, but from 2006 to 2008, the amount of vitamin C went up. So the dose went up, like, look, 31 grams to 50 grams, right? The frequency of treatments. So, before they're asking patients every 3.5 to 4 days, come get a treatment. And now they're saying every 2 days. So they're given more frequent doses. The dose is going up, right? So you're seeing you're in this 75 range to, 90, 95 or so, given more vitamin C, and they're giving it faster, right? And, the cynic, they're making money, right? Of course they want more treatments and they want to get it in you faster. Big dose is going to give more of an effect, right? It's the cynic would say, okay, well, that makes sense. And they've actually found out some industry data. They found out that 750,000 vials were sold, and 855,000 vials were sold in 2008. So we're getting more vitamin C and more patients here. And why were they giving it? So then they asked, okay, well, why are we getting it here? Mostly for cancer and infections. So it's interesting because most of the data, as you'll see, comes in fatigue. And it's nice that that's obviously number one right here. But it's pretty interesting how many different types of cancer they're giving it for, and many other infectious causes. There is less evidence for the infections here. And in my little corner of the world in New Orleans, I'm seeing more recommendations, I think, for Epstein-Barr, CMV, herpes, other chronic viruses. I think practitioners tend to have this idea that the IV vitamin C is going to help these chronic viruses. And I have never found focusing on chronic viral infections to be something that helps any patients. So glad it's low here, but maybe distressing here in my world. And that's a pretty good survey of who's getting it. So then the question is does it work? And absolutely, it helps fatigue. And so we have a ton of information now that vitamin C is going to do a good job for fatigue. And so this was a really neat study in long COVID. So patients who had COVID are suffering from a large degree of fatigue afterwards. These are 9 studies in a meta-analysis of over 700 people, so a good size group. And they found that 3 out of 4 controlled trials, and so there are 4 randomized control trials out of the 9, showed reduced fatigue. All right, so we've got a high level of evidence, to start here. We're doing pretty well. And the 5 observational studies or pre-post showed a significant reduction in fatigue as well. So even if you don't have a control, we're seeing it. So not as high quality evidence is here, but researchers also commented it's not just fatigue. So giving the IV vitamin C, patients would report sleep disturbances were getting better, brain fog, depression, pain. And so that's always something I'm looking for in my clinic. When I give a treatment, probiotics for the gut, and I see that not only does bloating and diarrhea go away, but someone's joint pain or acne or brain fog, right, is better. That gives me an idea that this is a treatment that is really fixing something. This is treating something, a root cause, a more profound reason why someone is ill. And so I was really pleased to see that, and a little surprised. I think I'm biased against these things just because I'm seeing the patients who come in and they tell me how much money they wasted not being better. So I was really happy to see high quality evidence here. And here's just one a randomized controlled trial. They took 141 office workers in Korea, and they either gave them normal saline, just regular IV, a bag of IV fluid, with just the fluid, or with 10 grams of vitamin C. Right now, 10 grams of vitamin C is, miles below what we saw people are giving, and who the hell knows what dose they're giving now. But 10 grams of vitamin C, what they found was that significantly better fatigue scores, right? After the infusion, and it remained lower for the next day. And once you start looking into vitamin C IV studies, you'll often find that they're using biomarkers to see, are we having higher levels of vitamin C? And then is it doing anything biochemically? So you'll often see lower markers of oxidative stress, saying, okay, yes, we think vitamin C is having an antioxidant, anti-inflammatory job. And like many other studies, this study showed that. But this is the fascinating part. They went one step farther, and they then took a look at some of the patients, and they had done a baseline vitamin C level. And what they found was that the patients with the lower starting vitamin C level, they kind of divided them 50th percentile, higher and lower levels, very, very basic. But those with low vitamin C levels are the ones who got the reduction in fatigue. So not everybody is going to benefit from vitamin C. Who shouldn't get it, right? So it's safe. So we'll start here. Here was a nice kind of big picture. You're not getting more adverse effects or side effects. You're not getting more than placebo. And so we'll talk about placebo, in depth in a little bit. But the big idea here is that whenever you give an IV, right, you have a risk of inflammation, infection, swelling, bruising at the IV site. And they're not seeing more side effects compared to just regular IV treatment. So in 2,800 patients, that's a really good mark. Saying vitamin C is going to be safe. And so I think that there really should not be concern, except for a few small edge cases. And because I think most of the IV clinics, they just want to sell IVs. And I think the unfortunate reality is they don't really care about screening everybody. So I want patients who have these conditions to know to be careful. So if you have renal insufficiency, if you have pre-existing low kidney function, or if you have G6PD deficiency, an inherited enzymatic deficiency, then you shouldn't get IV vitamin C, because there are case reports of harm. So there have been death in a few cases of patients with pretty severe kidney function bordering on kidney failure, but those patients were killed by the IV vitamin C. So you just have to say that. We need to protect ourselves if we have kidney disease. And then for the patients with G6PD deficiency, these patients are uniquely vulnerable to something called hemolysis. And this is a breakdown of red blood cells. And we commonly think of this as a few different medications that can cause this. But we now know that vitamin C given at high dose can also cause this breakdown of red blood cells. And you can imagine breakdown of red blood cells throughout your whole body can be a medical emergency. The only other side effects that I found that are worth mentioning is there are a couple of reports of kidney stones. So perhaps be careful if you have a history of kidney stones with IV vitamin C. And be careful if you have electrolyte disturbances. There are a few case reports of the body's sodium level becoming too high with the IV fluids and vitamin C. And then last but not least, I remember this when doing some research for continuous glucose monitors, and the fact that there were a couple cases where high dose oral vitamin C made the glucometer not work very well. And indeed, it was reported in this literature as well that, of course, high dose IV vitamin C can make your glucometer mess up. So don't be surprised if you are checking your blood sugar and you see weird things. But again, it's safe, all right? These are very small number of people who really need to be careful of this. most people in the general public can walk in and get an IV vitamin C at quite high doses and feel comfortable that it's safe. Even though it's safe, is it worth it, right? Is it worth the cost of, you know, we'll say about $170 to $270 per fusion? That's, what I'm finding is kind of the going rate for most IV therapies, maybe higher in different cities, but is it worth a reduction in fatigue to spend it? It might be for some patients. But then we want to look at this a little bit more skeptically. If you are a person who is very fearful, you have a lot of fear, you are very maybe mistrustful of the conventional medical system, it'd be very easy for a doctor selling IVs to convince you that this alternative treatment is the thing you need, right? And that makes me concerned when I see the number of treatments going up to every 2 days. I can't imagine there are very many conditions in which you need IV vitamin C every 2 days. Twice weekly vitamin C infusions at $170, that's $1,300 a month. So the question I always have is that going to be the best use of someone's resources? I think probably not if you are giving ongoing vitamin C. I think periodic infusions, if you're someone with chronic fatigue syndromes to help pick you up, might be a worthwhile use of your time and money. But we just want to be careful not to get hoodwinked into some of the subscriptions or packages where you got to buy a whole bunch of infusions. I don't think that that's going to be very helpful for most people. Okay, so I hinted at this earlier. Let's take a look at the placebo effect in IV therapies. And remember, the placebo effect is where the body can have a real physical response to something that's not a treatment, right? So we think that the placebo effect may be as high as 50%. Meaning if you take 100 patients and you give 50 of them a sugar pill, they may say, oh, my pain is better and I'm sleeping better and everything seems to be all right. And this is because the body will make endorphins to what it thinks will be a positive response, right? And certain medications are going to have a better placebo effect than others. So as an example, I've often worried or wondered about the capsules of itraconazole. They're this really vibrant, like pink blue color. And I've always wondered if you just gave someone a white capsule and this really rad, wild, brightly colored capsule, I think that the brightly colored one would work better. And I wonder if that's ever been studied. But you can imagine if you're given a capsule, you have an intuition about how this may help or may not help. Think of how much greater it is when you're pumping a material into your body directly, piercing the skin. The placebo effect is higher. And let's go through a really neat study that I found that can kind of illustrate how powerful a placebo effect can be in IV therapies. And again, I just want to say this because it may be worth it to pay for a placebo effect or it may not be, but we want to be honest and open about it. So they took 93 patients and they divided them into 4 groups. And what they were doing is they gave some of them just a regular IV saline drip. And I should say, these were patients in a lot of pain. They had just gone resection of a portion of their lung, usually for lung cancer. And so they already had a whole bunch of pain. They were expected to have a whole lot of pain post-op. And some of them were told just given a normal saline drip, but it was hidden behind a screen, right? They knew that they were getting an IV treatment, but they weren't really sure what or when, and they couldn't see it. Some of them were given a hidden injection, so hidden behind a screen, of proglumide. And I wasn't familiar with this compound, but what this does is it enhances the effect of endorphins. And the researchers in a separate trial found that it potentiated the placebo pain relief. It gave them a bigger pain relief to a placebo, which is kind of neat, right? 13 had visible IV fluid, but they were told that the IV fluid is a painkiller, right? You can see where that's going. And then 27 received the proglumide infusion and told it was a potent painkiller. So let's see. I know it's a little confusing, but you'll see a graph here. First, they said, okay, let's look at this proglumide stuff, right? When it was hidden behind a screen, right, it didn't have any effect because the patients weren't sure they were getting a treatment. It wasn't like, hey, this is really going to help your pain. I'm going to get it in you. We're going to push it in. You're going to be feeling better in 20 minutes. They just were given this medication at, quite a big dose range, 0.05 all the way up to 5 milligrams, right? 100 times dose increase. But if they didn't have that placebo effect to potentiate, they didn't get any relief from pain, right? But what happens in that full big trial of all the groups? So no treatment, no pain relief. Makes sense. Then take a look at the proglumide. They're giving the proglumide infusion and saying, this is really going to help your pain. And they give it at 3 different doses. And the higher the dose of proglumide, the higher the pain relief. So you're getting they should sell this stuff, right? It's pretty good. The pain intensity is going way down. But if we want to look at the placebo effect, the IV placebo effect, we can compare the patients who had no treatment with something that has no ability to induce pain relief, just normal saline IV. But when they were told that it was a pain relief, they got quite a bit, quite a bit of pain reduction compared to no treatment. So we know from studies like these that giving IV treatments done the right way can cause pain relief, can cause a physical effect in the body, right? You see a physical effect of making endorphins. It's enhanced by the medicine. And you see that just IV treatment can help people with pain. It's a really, I think, important reminder that IV treatments can be based on this endorphin placebo effect. So we just want to be open to the fact that sometimes IV treatments may not be doing anything. And we'll get to that with some of the studies that I'll talk about in just a moment, but they may not be doing anything physically for the body, but it may be more the placebo effect that's giving us the treatment. And that's what medical literature can help us understand. Okay, let's move into another very popular and very common treatment in alternative medicine, and that is the Myers cocktail. So the Myers cocktail is a kind of specialized blend of water-soluble vitamins, and it's historically been given, and again, this has been done for decades and decades in alternative medicine circles. It's a blend of B1, B6, B5, calcium, magnesium, vitamin C, given in a large, like 50 cc syringe, and it's slowly pushed or given just dropped into an IV bag. And what I see happening is that a lot of IV clinics will offer this as kind of their base IV infusion. And the idea here is that you want to get potentially higher levels of nutrients in your body in the serum by IV than you can get while just taking these vitamins orally. And so the doctors that sell this are promoting the idea that super high levels of nutrients are going to give a better therapeutic effect than just taking oral pills. And I'm seeing them use this as the base and then almost a la carte add-ons. If you want to get NAD for mitochondrial health or glutathione for detox, zinc for immune health, you can add those on for an extra fee. And so the question is does this work? Does it move outcomes? Because we don't want to do something just because we can bump up a level of magnesium in the body. We want to know, does it actually make a clinical condition better? And you can read a lot by Alan Gabby there. His citation is down below. He is a doctor who almost a folk hero in alternative medicine for his work on nutritional therapies. And he's given many Myers cocktails over his career and writes, I think, a pretty fair article summarizing what's known about it and what's not known. So a couple of good things I learned while looking into this. The first thing is that IV magnesium is a real treatment. We know that there is good clinical evidence from emergency medicine, knowing that we can abort asthma attacks in kids. We know that IV magnesium is effective at aborting migraine headaches. We know it's used therapeutically by OBGYNs. And so we know that IV magnesium has clinical benefit to it. But when we get to this combination, this special combination in the Myers cocktail, the truth is that most of the evidence is anecdotal. It's the doctors who are selling and providing this treatment who are reporting how how beneficial it is. But what they say is asthma, fatigue, fibromyalgia, depression, respiratory infections, allergies, cardiovascular disease, and more, right? So there are a whole wide range of treatments that they say this is good for. And happily, there's been studies, right? So if we don't have a study on something, then maybe we take the clinician's word for it. And when we have a trial, I think we owe it to our patients to look into it, right? So kudos to these researchers who actually took a question, does the Myers cocktail work? It's on the rise. We're seeing more and more sales of the Myers cocktail. Does it work? Right? Let's look in fibromyalgia. So they took 34 adults and they gave them either the Myers cocktail or placebo for 8 weeks. So a good amount of time, right? They're really going to bump up nutrients. If it's going to work, we're going to see it. And they measured quite a lot of pieces of information, trigger point pain, a visual analog scale, right? That's a 0, 1 through 10, sad face to happy face. What's your pain? Physical function, mood, quality of life. And really importantly, remember, the Myers cocktail is almost neon yellow. So they blinded both the patients and the nurses giving the infusion to putting an opaque sheet over the syringe so they wouldn't be biased one way or the other, knowing what treatment is being given. And what did they find out? Well, they found out that either giving the Myers cocktail or just IV fluid both helped in fibromyalgia. But there was nothing special about the Myers cocktail, right? You can see from the data from the study, right? They both got benefit, which is great, but there just wasn't any difference, any better difference over placebo for giving the Myers cocktail. For fibromyalgia, we can count out Myers cocktail as being something that's uniquely beneficial. And I think we could take this one step further, right? I see a lot of patients with chronic fatigue and they come in and they've been diagnosed with fibromyalgia already. And almost to a person, they've been sold vitamins, their neighbor, their doctor, a health coach, marketing online. And they have this idea that if they just get the vitamin C and the vitamin D and the B complex up, that their fatigue will go away. And this is a really important piece of information to say that's just not a good therapy for chronic fatigue. It doesn't work. And I see in my clinic, and I'll often stop those right off the bat because we're not getting benefit. But giving high doses of these vitamins by IV didn't make a difference. And so what good is just some of these oral vitamins going to be doing for these conditions? Probably not very much, right? So we can say Myers cocktail for fibromyalgia, not that great. And again, the researchers commented, I think a very fair study, but a strong placebo effect was noted with both IV fluid and Myers cocktail, but minimal group differences. Okay, this has been one of my favorite things to research over the past couple of years because the first TACT trial came out in 2013. And what this was a really, really well done scientific trial trying to ask the question, does chelation help reduce heart attacks? Because as you'll see, EDTA is a chelator. It binds to positively charged elements. So you can think of calcium, magnesium, aluminum as positively charged elements that EDTA will form a complex with. And when you form this complex, you greatly improve the body's ability to excrete this in the urine, right? The renal excretion goes up. So, but not only those nutrients, but lead, cadmium can form a complex with EDTA. So doctors who are very interested in removing heavy metals from patients have been giving this therapy for decades. And this really, it goes back to the 1950s, right? And so the theory here is that we know that atherosclerotic plaque, hardening of the arteries, the fatty disease that builds up in the vessel walls, when you get enough plaque in the artery, the body will put calcium in it, right? And so we've known this for a long time. And in the 1950s, the doctor said, well, if we have all this calcium associated with the atherosclerosis, what happens if we pull the calcium out of the vessel wall? Could we maybe make the plaque go away? Could we reduce heart attacks? And so it's been used, EDTA, for decades and decades and decades, right? 60, 70 years now, with the idea that we can pull calcium down and reduce heart attacks. More recently, it's been used to detoxify heavy metals. And I want to spend some time in a moment talking about that. But decade by decade, it's growing. It's growing in use. And the truth is that there's no clear indications for what groups of patients should get it, who should get it, does it work, does it not work? And so that's where the TACT trial came in. It really wanted to ask the question, does IV chelation of using EDTA reduce heart attacks? Let's find out once and for all. But before we do that, let's just take a step back and talk about lead. This is a soapbox. I've presented this slide before in lectures, but it's just so important to say again. And the fact is that low-level lead exposure kills more Americans than smoking. Really well done study. And the reason why this is so, it seems counterintuitive, but if you take smoking as a risk factor and low level or medium level lead exposure, smoking is a worse cardiovascular risk factor. But the fact is that only 20% of Americans smoke now. We've been saying smoking kills people, and Americans agree, and they've dropped their smoking habits. But we're still being exposed to a lot of heavy metals. And that heavy metals carries a lot of cardiovascular risk. And so many Americans are being exposed to low levels that we think it's killing a whole lot more people than smoking. It's really scary. And, when you go to your PCP, they're checking your blood pressure and your cholesterol and your blood sugar, and they should do those things because those are risk factors for developing cardiovascular disease, heart attacks, and strokes. But they're not yet checking blood lead. And this is the thing I really want people to change. Every single adult, if you're age 50, you're getting cardiovascular screening, get a blood lead level. It's a very simple, inexpensive test that can be done at any lab in the country. And I think that a lot of people are going to live longer if they simply do that. So before we get into the TACT trials, I just want to dive in a little bit on what's a problematic blood lead level. So here are some of the studies on the right here that you'll see where this information comes from. And some of this will come from my clinical experience, but we'll start off that there's no safe level of lead in your body. Even very, very small amounts cause problems. So one good thing is we've learned more about metals is that it used to be, 10 is the cutoff for when we treat. And then it kind of went down to 5. And then recently we're getting really, really good information that even tiny levels, levels of 1, 2 are a risk factor. And so where we can begin when looking at blood levels as they increase is I would begin with a blood lead level of 2. And that's because that's where we see a turning point where risk really starts to go up. So we know that a blood lead level of 2 means there's really a 30% higher risk of cardiac death, right? That alone should be concerning and a big eye opener. And then of course, the higher it gets, the higher the risk. So when you get to a blood lead level of 6, you're starting to see all sorts of risks go up. All-cause mortality, death of any cause, cardiovascular death, 70% more common in those with a blood lead level of 6.7 versus 1. Ischemic heart disease, 2 times the risk. I mean, these are big time HRs. These are big risk factors. But the key here is that you won't have any symptoms. Really, in my clinic, I haven't seen symptoms until the blood lead level gets to 20. In this article, a review article, they said 25 is the cutoff. But the point of the matter is so many Americans are walking around and they're a cardiovascular time bomb. These metals are hurting the endovascular cells, right? They are really weakening the ability of the arterial wall to be consistent. It's making it more vulnerable to LDL. I think it's just a really big risk factor that's being missed. So symptoms go up as blood level goes up, and you start to see neurologic symptoms, right? Over that, say 20, 25 range. You start to see bone marrow toxicity at 50, right? The lead is poisoning the bone marrow and it's no longer able to make red blood cells. We see kids get neurologic symptoms. We see poisoning of the GI tract. And then you start to see, the encephalopathy, the kind of deadly intracranial hypertension, delirium, frank neuropathies happen when the blood lead level is over 100. I don't see those clinically. I see levels 20 and below. And most times patients are coming in and their blood lead level, it may be between 2 and 5, and we're treating it from that range. Again, not symptomatic, right? No symptoms, but it's a cardiovascular risk that we want to take care of. So enter TACT, the TACT trial, right? Such a well-done study, right? So kudos to this. You'll kind of hopefully get some appreciation for the work that these really great researchers did. So 1,700 patients, and 55,000 infusions. And what they did was they randomized patients who previously had a heart attack. They either gave them the EDTA, a little bit of vitamin C. So that's good, right? They either gave them the chelating agent, vitamin C, and a multivitamin, or placebo, just gave them an IV infusion. And they treated them for a long time. They gave weekly infusions for 30 weeks and then 10 additional infusions, so 40 total. And one key point is that, if you're setting up a trial like this and you want to treat 1,700 patients, where are you going to do it, right? You do it in the clinics that are already set up to give infusions like this, right? So mostly they're at for-profit infusion clinics. They're being manned by the doctors who have a financial incentive to sell chelation therapy, and that will come up. There were a lot of dropouts. So this is a long study. It's a lot involved. 15% dropped from side effects. But, they weren't just saying, okay, well, if we give EDTA, does it, tweak the blood pressure a little bit? They're looking at the things that count. They're looking at really good cardiovascular and mortality outcomes. And they're followed for 5 years. A big question. Do patients who have known coronary artery disease, do they benefit from chelation therapy? And to set this up, this is in the medical journal JAMA, the most conservative, evidence-based, well-respected, one of the most well-respected journals you can have out there. And this was really done because the conventional doctors say, all those quacks, giving chelation therapy, we're going to stop this once and for all, right? It doesn't help heart disease. What are they talking about? We're going to make the best study possible and show them they're wrong. Okay. And then you have the alternative doctors saying, look, my mentor and his mentor, we've been doing it and we think it's safe and we think it's helpful and we're going to show you what works. And so you have this kind of clash set up, right? So high drama in the medical field. So with that background, what happened? Did it work? Did we see less heart attacks? And amazingly, shockingly, the study that's supposed to put chelation out of business forever supported its use, right? So we see the primary endpoint dropped in the treatment group. So only 222 endpoints. And again, mortality. So we're seeing heart attack, stroke. Do they need a stent put in, the revascularization, and hospitalization for chest pain? So heart attack, 6% versus 8%. Stroke, 1.2% versus 1.5%. Hospitalization was down, right? We're seeing clear cardiovascular benefit in mortality. And they said, okay, they were smart. They said, we know that some patients are at higher risk. Let's really analyze some of those subgroups. Let's look at older people. Let's look at women who are high at risk. Let's look at patients who are not being treated with statins. Let's look at diabetics and look at people with a high risk MI. And that means an anterior myocardial infarction. So we know anatomically patients who have a heart attack in the front wall of the heart versus the back posterior wall, they're higher risk, right? Less likely to survive, more likely to have complications. And indeed, they found that diabetics and patients with that anterior location had the biggest benefit. And so here's what it looked like, right? Here's what diabetics look like. Here's the placebo arm. And then here's the mortality benefit in diabetics, right? That's a huge, huge shift in the KM curve. Really, really something. And so the trial was positive, right? And so to make things even more fun, right? So we get this kind of landmark clinical trial saying, surprise, chelation therapy works. It's saving lives in diabetics with heart disease. How many diabetics with heart disease, do we have? Millions and millions in the US. We could be saving a lot of lives. And so the alternative medicine doctors kind of did a victory lap and said, I told you so. And then the conservative doctors put an editorial in the same journal article right next to it. So here's all the problems with this study, right? They point out some, I think, legit criticism of the study. The dropout rate was high, like 1 in 5 patients. and more in the placebo group. And why does that matter? Well, I told you that the study was done by doctors who sell IV treatments for a living, right? And if either the patients or the investigators over week after week, someone figures out that they're getting a placebo group, if they are a patient who already kind of thinks that this is going to work, right? And they realize they're in placebo, they're like, I'm not going to stick around for 20 more weeks. I'm only getting IV fluid. I want the real thing. So that they may drop out. So if you have this dropout group placebo higher, then you might not be blinded, right? It might not be a good sample. And they pointed out that, look, these doctors sell IV treatments, that most of these were not, they were not independent centers, right? And in a big clinical trial like this, it's bad form to look at the data before you're done with the data collection. So it might be that to make sure you're on track, getting enough people through, there's no problems with the centers, you might look at the data 2 times, 3 times, throughout the period of time. But these doctors were peaking, right? 11 times while the study was ongoing. That's a lot, right? And that doesn't prove, but it suggests that maybe they were biased in wanting to look for a certain outcome. And maybe if they're looking at the data and they don't quite see what they want, maybe they're going to change their behavior, or maybe they're going to kind of, do something different to try to influence it. So we get another level of intrigue, right? We get this alternative medicine versus conventional medicine. They're saying, okay, we finally got the trial, but now you got to put the snarky editorial. But what's really happening? Does it work? Are we missing an important treatment for diabetics? We should be making this standard of care, heavy metal chelation. The researchers pointed out the problems with the trial. Were those real methodological concerns? Was the study not done the right way? Or was it just sour grapes? They were wrong, right? So this sets up TACT 2. This sets up like the rematch, right? Heavyweight fight number 2. And the TACT 2 trial then says, all right, we had, I think it was 250 or so patients who had diabetes, were given the heavy metal chelation. It's like, all right, now we're going to take almost 1,000. We are going to power the study up to really see if this works in diabetics, right? And the study went pretty well. So similar dropout rates. There was nothing very, very different about the follow-up trial. Same study design, 40 infusions, followed for 5 years. And except they just focused, kind of narrowed in on the group that got the most benefit. Does treatment with heavy metal chelation reduce cardiovascular events compared to placebo among diabetics who have heart disease? That is the question. What's the answer? What is it? No, right? No, it was not effective. So they found that it was not effective in reducing all-cause mortality, heart attacks, stroke, stent, or hospitalizations. And so for this one, this is just one of the things. We are very lucky to live in the year 2025, where we can ask these questions and get answers. And when we're unsure, if we don't have enough data, we can do it bigger, we can do it better and really answer. But it's also important that we revisit our preconceived notions when we get more evidence. So in this case, I know that there are still doctors out there saying heavy metal chelation will prevent heart attacks, right? Look at the TACT 1 trial from 2013. All right, this came out a year ago, September 2024. It is so important that people change their tune when we get better information. And this is better information. It's more accurate information, and it clearly shows that it doesn't work. So heavy metal chelation is not something that we should be using in clinical medicine to reduce heart disease. And if you see a doctor out there who is selling EDTA and marketing it for cardiovascular benefits, you should bring them this study. And you should realize that they are financially biased. They are giving you outdated information. They want to sell IVs, and they don't care about outcomes. That should be all you need to know whether you should continue to work with them. And I get a little pissed off about this stuff because in my field of functional medicine, I am seeing so many patients being hurt because the doctors are just selling. They're selling too many pills. They're selling supplements. They're selling labs. They're selling IVs. And quite frankly, Once the money starts coming in, I think the blind eye to science happens. They don't want to see anything that's going to interrupt their income flow. And I know a lot of people don't want to hear that, but that's the truth. And so I want to arm well-meaning practitioners and patients with the information to protect themselves against those who just want to sell you nonsense and steal your money. I probably won't be invited to as many alternative medicine conferences, but that's just got to say what you got to say, right? Okay. I was going to end the video there, right? Kind of nice conclusion. But as I started doing more research and looking into what the different alternative medicine clinics were offering, I came across this Plaquex treatment. And it took me a while to figure out what it was because the science is not very good. And we'll talk about this. But Plaquex is being marketed as this kind of miracle cure for cardiovascular disease. You want to improve your vascular health, improve your platelet function, and lower your cardiovascular markers. And Plaquex is going to clean out your arteries, right? I'm seeing more and more of this. I said, what the hell is this? And honestly, am I missing something? Could this be something that I need to offer my patients, right? My bias was it's probably nonsense, but let's check it out. So here's what we found. Okay, number one, it took me a while to figure out what the hell it was. You just hear Plaquex because people want to sell Plaquex because it sounds exciting. It's a form of phosphatidylcholine. And you may remember from beginning biology that phosphatidylcholine is a phospholipid, and phospholipids make up the cell wall, right? You got the bilayer of phospholipids, and it's a very critical, mission critical molecule. If you don't have phospholipids, you die because you can't have cellular integrity. And whenever you have a critical molecule, you hear a lot of bullshit about it, right? Because you can tell all these stories. Well, the cell receptors won't work well if you don't have, a proper phosphatidylcholine. Well, if you get this toxin, it's going to move the way that the phosphatidylcholine impacts the next phosphatidylcholine, and you may have less hormone regulation through the cell wall, or you may have all sorts of stuff, right? But the question is, does it actually work, right? Who cares if it reduces the triglycerides 5%? Who cares if it moves an anti-inflammatory marker down? Does it prevent heart attacks? Does it prevent strokes? Does it make you live longer? Does it drop mortality? I copied and pasted this. It's from the Plaquex website, as is this really wonky image from the 1980s, because this is kind of copied and pasted across a lot of the marketing. So this is some of the marketing you'll see, right? Plaquex, it supports heart and artery health, right? When support is a weasel word. If you see support, if you see restorative infusion, protect cardiovascular health, clear arterial buildup, right? These are big claims. And you want to really make sure the doctor has good evidence. They want to inject this compound into you. Does it work? And this stuff is not good enough, right? You want to know outcome data, and there is none. And I spent about 8 hours, a full workday, trying to pull the studies. And if you go to the Plaquex website, there are citations in German and Russian from like the 1970s. There's no modern science. These are not reliable studies. There's not reliable outcome data. You get things like this graph, this graph that, shows you can't find the data. You can't track if they just made that up or not. You don't know. But on the website, look, Plaquex will drop your total cholesterol. Not that it will prevent a heart attack or stroke, but it will move a number on a piece of paper. And then if you stop giving it, it goes up, right? And of course, they love that one because then they want to sell more treatments, right? This is 10 treatments over 10 weeks. And so, of course, they want to show you if you stop giving it, the benefit's you're going to lose the benefit. Here's what this comes down to. This infusion costs on this clinic $270 for a single infusion. The doctors who are recommending this recommend between 30 and 60 infusions. And this is what pisses me off. They're relying on bullshit studies from the 1960s in German. I guarantee you they've never read it. I guarantee you I did more research trying to find out if it works than they did. And 30 infusions at $270 is $8,000. 60 infusions is $16,000. The reason why they're pushing this molecule is not because there is solid scientific evidence, it's because they find one schmuck who will want to inject this stuff into their veins on an ongoing basis. They make a lot of money. That's just how it is. And I just feel like more of this information needs to be out there so people can protect themselves, because this is a lot of money. It's a freaking car. That's a down payment on a house. This matters, and this hurts people. And we've been trained to first do no harm. We don't want to give a treatment that can hurt someone. But if you bleed their money, you're hurting them. So I get a little upset about this, but the conflict of interest in alternative medicine is really, really ridiculous. You have a lot of doctors who make at least 30% of their income selling supplements. So they're going to be not biased on, will this help you or not? Or am I just making a sale? They're selling labs. Will this help you or not? Or am I just making a sale? And they're selling IVs. Don't really care if it helps you because I'm making money. I don't know how else to think about it or how else to say this nicely. But imagine going to a conventional PCP and they sign you up for an email and you're on their email marketing and, hey, welcome, it's January 2026. Come on into our clinic because it's 2-for-1 Crestor. Buy 1 month, get the second free, right? We've got a deep discount on losartan. Get your blood pressure down. It's the new year. It would be ridiculous, right? Could you imagine a store in your doctor's office and they're selling you your Zetia and it's laughable when you say it like that. But you go to an alternative medicine and they've got their shop, right up front. Here's all the supplements I'm selling. And you work with doctors online. They've got their online shop. Doctors should be doctors. They shouldn't be selling this shit. Okay. One of the points I'm trying to make is that moving numbers on a piece of paper does not mean outcomes. So this is a trap that a lot of alternative medicine doctors, a lot of conventional doctors fall into. If you are going to obsess about a marker, you need to know that it's a marker that matters. That if you drop it, that you'll lower events, or if you raise it, you'll affect the disease outcome. And I always like to use the example of HDL because it's something that people kind of intuitively know. They know that it's good to have high levels of HDL. And we've known for decades with every single study that generally speaking, higher levels of HDL mean that people have less heart attacks. And so naturally the drug companies say, geez, well, maybe we can raise the HDL and lower heart attacks. But again, and again, and again, as they've tried different molecules and drugs and supplements, it doesn't work. You can move the HDL up, but if it doesn't significantly impact outcomes, who cares, right? And so, for example, the 2010 Accord trial, they did just this with fenofibrate. We know you can give fenofibrate and bump the HDL. But in the end, you give patients who are on statin, who have diabetes, you give one group placebo and you give one group fenofibrate. There was no significant difference. And so we don't want to move a number unless it moves an outcome. And this is where you say all these things, but unless you can prove that something is making you have a disease-based outcome, then you're wasting your time. And so patients need to demand that of doctors. Doctors need to demand this from labs, right? Don't just sell me some panel that will detect all these things. Does detecting and treating that thing make a difference? Because if not, it's a waste of time and money. And I couldn't stop. Okay, so this came from the Plaquex website. This is like their marketing picture. And anyone with a basic knowledge of cardiovascular medicine, I think they understand that if you have a plaque in your vessel, you've got an atherosclerotic plaque, and you rupture it, and you have all sorts of ruptured plaque going into your bloodstream, two things are going to happen. You're going to have a heart attack, or you're going to have a stroke, right? So don't let Plaquex scrub your artery vessels and give you heart attacks or strokes. I just found this picture amazingly telling, right? Don't let them scrub away this. It doesn't work. It's a sales job, right? There you go. Takeaways. IV treatments come with a placebo effect. And that may be okay. If the cost is low enough and it's safe, then maybe it's worth a couple $100 for a placebo effect, right? That I think that's up to you as a patient, to you as a doctor. If you want to say maybe this person really could use a bag of IV fluid, see what happens. Takeaway 2, high dose vitamin C. I changed my tune on this. It's safe. It's effective, especially in fatigue. There are other conditions where I think it might be a good idea. You may notice that I didn't say anything about cancer. There are so many studies on vitamin C and cancer. And honestly, I'm just not qualified. I'm not an oncologist. I don't treat cancer. And so I wanted to keep all of the vitamin C and cancer discussion to experts who can actually interpret it. There's so many studies there that I couldn't even crack the beginning of them with an hour-long YouTube video. You need a book, right? You need an encyclopedia. There's so much there. And there's so much there that I think that there is benefit in some, but I don't have the expertise to say which conditions and when and what dose you would want to be considering that. That would be for someone else. IV magnesium is a legitimate medical treatment. Takeaway, Myers cocktail is no better than placebo. I don't think you should be spending money bumping IVs for no good reason. Most Americans are not nutrient deficient in a clinically important way. And we can tell that because when people have chronic fatigue and you give them nutrients, they don't get better. And I see that in my practice too. Not to say that if you have iron deficiency, you shouldn't treat that. There are clinical deficiencies you want to pay attention to, but run-of-the-mill bumping vitamins is a waste of time and money almost always. We want to be very clear that IV chelation of heavy metals does not reduce cardiovascular outcomes. Doctors shouldn't be doing it. I don't know what else to say. If you have a blood lead level of 50, you should be getting EDTA. If you've been poisoned with lead, there is an FDA indication for EDTA in acute toxicity, but that's really it. I'm not sure that there's a place for this in the vast majority of clinical practices. And, to conclude, be very wary. This is for the patients. Be very wary of doctors infusing fancy sounding molecules into your body unless they can prove that they can change outcomes. Not just we can change triglycerides or we can shift your HDL or we can lower your total cholesterol or your blood pressure. I don't give a crap if they say it improves your platelet function or supports your vessel longevity. Make the doctor show you that it will improve your health. Where's the data? Patients, you need to protect yourself because unfortunately the reality is a lot of doctors just want to sell. And so that's part of this video is I want to arm you with the ability to be able to think about this stuff a little bit more critically and just call it as I see it. And big picture, you don't want to pay to be a guinea pig, right? You don't want to pay to be in a clinical trial for phosphatidylcholine. Let them do it in a controlled research subject. Don't pay a doctor to experiment on you. So with that, if you are still watching, thank you so much. My goal is to teach doctors. I want to reach more doctors. I want to teach them the things in functional medicine that help patients. I want to move the field away from selling, and I want to get it back to the things it does the best because I know that functional medicine helps so many patients that conventional medicine can't. But what it can't do is get trapped in sales. And I worry a lot that the field I love, functional medicine, is being taken over by lab and supplements and IV companies. And it worries me, just like I worry that conventional medicine has hit a dead end because of pharmaceutical companies. So I worry about the field I love. And if you've watched this far, please share the video with someone who could benefit from this information. I really just wanted to get good information out to people and doctors. So thank you so much. Take care, and we'll see you next time.